Good evening. I'd like to welcome everybody to the May 22, 2022 meeting for the Pitt County Board of Health. We'll go ahead and call the meeting to order. And first, we'll hear any public comments. All right, hearing none, we'll move on to the minutes. We do not have quorum, so we cannot vote. What do you think? Table this, John?
Yeah, I think we would have to, and
Yeah.
we can approve them next month and finalize them next month.
Okay, we'll do that. We'll skip the minutes for this month because we don't have quorum. We will hear next the fiscal report with Marcia.
Hey.
Good evening.
We are looking at period 10, which ended April the 30th. We had two budget amendments totaling $232,000. That was state funds. Just a little bit of background on those two budget amendments. Roughly $18,000 was for food and lodging, and $214,000 was for our school nurse program that we will be doing some work in the school nurses and contracting with Vidant and Pitt County Schools for that work, which brings our overall total to roughly actually $16.9 million. In a perfect world, we should be the pro rata at $14 million. Moving across your spreadsheet, we are at a surplus of $1.7 million. We do have some encumbered items, including the Smile Safari. The only thing that pro rata versus actual is the state funding, and that is the funding that we have where you do not pull it down unless you've spent it. So we've had a surplus of some of the COVID funding items for funding for some of our programs. But we do have a surplus of $1.6 million, roughly, at the end of April. Any questions about April? We can look at the grant. That's your second page. We only had movement on two of our grants, and that is our Triple P Positive Parenting Program and our HIV pre-exposure program, and that program will be ending as of the end of April. That program was sunset by the state, and those funds will be returned to the state. But we are overall $1.89 million in grant funding. And as we move across as of yesterday, we were sitting at 28 vacancies at the health department. We did have some movement. We did hire 3 people in the business office, which I'm very excited about, but 2 of those were internal employees. So super excited they are actually training, and I look forward to reporting about their progress next month.
Marcia, I think last month we had 30 or 31 vacancies. I'm trying to remember. So
That sounds about right.
We're down, we'll say 3.
Yes,
Were
sir.
what's the deal with those positions? If we were hired internally, that means something else.
Those other
Would have
positions would open up, but Jennifer did hire quite a few people in the past 3 weeks, and they're in various stages of orientation. We did get another 2 resignations since.
One that I'm aware of.
Okay, I think there was one. I'm not sure if we announced that last month. Or one of our investigators, she put in her resignation, and then we have another nurse that just recently turned in a resignation this week as well. So.
Do you have any update on the mobile bus for the Smile Safari?
I'm assuming no news is good news with all the supply chain issues.
Okay.
I really did like Mr. Gus, who was our point person. I thought about calling. To be honest with you, we've been working with Dentrix with the bus going around to all the different schools. All the schools are different locations. They're actually separate dental clinics inside of Dentrix Enterprise, so we can kind of track the profits or the progress and the reporting per school. We do have a lot of kids in Pitt County schools that are transient. You might see them at one school, and then by the end of the year, you can pick them up again at another school, which is kind of a interesting trend I've seen with the Smile Safari. So, but yeah, the Smile, I'm hoping no news is good news with the bus, but we were expecting them not to be complete till a year out. But I can call them and see.
Maybe let's try to get an update for June just to see.
I sure will.
What we've got.
Absolutely. Dr. Silvernail presented the budget to county commissioners last week.
Yeah, I
the
believe that was the
Tuesday?
Tuesday from HELL last week.
Yeah, it was a crazy week.
Not
But he
because of the
presented.
commissioners, but
Yes. But other than that, business office is still, we're just training our new folks and trying to stay ahead of Medicaid transformation. There's a lot of back and forth with the PHPs. Sometimes they pay us, sometimes they don't. Sometimes they give us interest payments, sometimes they garnish. So it's been a very big learning process. But Medicaid cost study did get finalized from last fiscal year. That's a really huge undertaking. It takes about 4 of us to do our different parts of it. We contract that with the Public Health Authority Alliance. Stephen Gardner. He works his magic, and it looks like we'll be getting a substantial amount of money back. So hopefully I can be reporting on that in a couple of months.
Very good.
As always, it's very busy in public health, so if y'all have any questions, feel free to reach out.
Any questions for Marcia tonight? So we won't take action on the fiscal report.
Okay.
We'll table that for June.
Sounds good.
Thank you, Marcia.
Thank you.
Next, we'll consider any items of old business. And hearing none, we'll move on to the new business. We have a report from the Regional Infection Prevention Team with Dolores Nobles and Evan Clayman.
Hi, everybody. How are you today?
Good evening. Thank you for being here.
Good. We're a regional infection prevention support team formed out of the North Carolina Department. Hey, Dr. Garrison. Formed out of the Department of Health and Human Services and Department of Health Services and Research. But anyway, it's Evan Clayman and myself, and we work within the assisted living nursing homes of Pitt County, Beaufort County, and I'm going through all that to show you where we are. We're Region 10 infection prevention for the region. So what I want to do to you first is show you that our team role. We have regional infection prevention support for all the regions that we do. We go to long-term care settings, nursing homes, and all. We review infection prevention practices such as hand hygiene, personal protective equipment, injection safety, environmental cleaning, disinfection, which to me is one of the most important things you can do is disinfect and clean from viruses, bacteria, whatever that's out there all the time. And the outbreak management, which we did a lot of last year because COVID was raging. Places were in outbreak. We would go in to help them to get everyone under control. And we conduct infection prevention education with the staff because we saw there was a gap as far as infection prevention knowledge within some of the nursing homes and assisted livings. We work with other team members within the state to provide infection prevention guidance to the long-term care facilities. I worked at Pitt Memorial Hospital, Vidant Health. I call it Pitt because that's what it was when I started. Vidant Health. For 28 years, and the last 20 years were in infection prevention. So I tell people, I know my bugs and drugs, okay? You give me the bug, I'll tell you the drug. So I felt like, yeah, this is right on time for what we need to do. But we developed and revised tools to help them navigate when they have an outbreak, to navigate an infection, to navigate anything that could interrupt health care for our most vulnerable population that are in these long-term care. We assist in investigation, control, education, and prevention and care activities to help reduce the mortality and morbidity associated not with just COVID, even though that's what it's all about right now, but with other infectious diseases or transmissible diseases that come into their facilities. We collaborate with the Department of Public Health as well as the state and the SPICE program, which is the state program for infection control and epidemiology, where we get most of our guidance for infection prevention and infection control. And we use that when we go out to let them know we're your resource. We're your local resource right here and now. Call us if you need help. If we don't know the answer, we can definitely get it because we have all the people at the state level that can give us the answers to give to you. The Region 10 counties include these 9 counties. So we are out and about in all of these counties all of the time. I think the farthest when we went out is in Carteret County in a place called Sea Level. It's like it's hanging off the edge of the ocean. Because it's about 2.5 miles from Greenville. I thought I was in another state when we went out. But we do that. We travel out. We go into these facilities. We call and we get permission to come in and do these infection control assessments. And we identify gaps and we let them know. They ask us questions. We give them information. We give them tools. We give them kits. We give them anything that they need that they can't get from the state that they may have to do the job of protecting their residents, the staff, and any visitors that come in that door. Now, I'll let Evan go through some of the stuff that we see?
So some of the recommendations that we make to facilities, including designating a person who will coordinate their infection prevention program. That person, especially in a nursing home, that's a full-time role. That person is responsible for the health of every person in that facility. They're responsible for preventing the spread of an outbreak, preventing an outbreak from happening to begin with. They're responsible from basically A to Z for infection prevention. We want that person to be trained, ideally by the CDC or SPICE. And the CDC is currently offering free training to staff. And we strongly encourage anyone who's running an infection prevention facility or an infection prevention program to be trained by the CDC or SPICE, which we've mentioned before. We also recommend that they enhance infection prevention knowledge base among their staff members. For example, I mean, if you have like a housekeeper, a housekeeper has a very important role in infection prevention. That person is dealing with cleaning and disinfecting an entire facility where they might have diseases like C. difficile and norovirus. And those diseases don't get killed by, basic cleaners that they have, even state-sent cleaners like quaternary ammonium compounds or things like that. These are hospital-grade disinfectants. And they'll have staff members, and if the staff members aren't trained, they'll just assume this is good to use, but then they use it, and we've actually seen staff members likely get themselves sick and infect themselves with certain pathogens because they're using the wrong disinfectants. We also recommend for them to improve incomplete and inadequate infection prevention policies. That's your hand hygiene policies, PPE policies, like standard and transmission-based precautions. Transmission-based precautions are those precautions you take for certain diseases. And we recommend for them to institute processes for assessing staff competency on job-specific tasks, like implementing auditing of hand hygiene performance, PPE performance, injection safety for like assisted blood glucose monitoring. We also recommend that they ensure the appropriate use and storage of PPE. We've seen a lot of facilities that will store PPE out in old, dilapidated sheds, and we try to work with them as well as possible to make sure that anything that's coming in contact with a resident is something that's not contaminated with mold, something that hasn't been around rats, mice, stray cats, anything like that. And we see it all. And we constantly work with facilities to improve the storage of those things so that those don't spread diseases to their residents. Promote proper use and knowledge of disinfectants. That's something we kind of just touched upon. And improve communication with local and state health partners. We especially work on making sure that our facilities have good collaboration with their local health departments. Some of our performance measures, we aim to conduct site visits to nursing homes, every nursing home, assisted living facility, mental health home, and family care home by July 31st, 2023. We also aim to complete educational sessions with these facilities, and we basically assess whether or not they need education in certain areas and then recommend that education accordingly. So these graphs kind of show the visits that we have conducted. The total visits are in dark green, and those include initial visits that we've made and follow-ups with facilities. So you can see for Pitt County alone, we've made roughly 60 visits, and we have about, 15 remaining for Pitt County. But we work on every single day on covering the rest of those facilities that we've yet to hit. Those are mainly, as you'll see by the next slide, those facilities that we've yet hit are group homes, so mental health homes and family care. But we have visited every assisted living facility in our 9-county region, and we visited every skilled nursing facility besides 2. So this is the RIPS dashboard. So this is a dashboard that was created by the DHHS. This dashboard basically shows, it shows a whole bunch of data, but the important data in this is what gaps are prevalent in certain types of facilities. So, the biggest gap that we see is in outbreak management. We see staff members who don't want to adhere to transmission-based precautions when dealing with COVID cases. They may think they don't need to wear any PPE at all when they interact with residents. And that can get themselves sick, that can get other residents sick thereby. So we work really closely on managing outbreaks so that they can prevent a full-fledged outbreak in their facility. And this last one basically just shows where our team is in relation to other teams. You can see by these bars on the right, we are the gray region, and we have done almost as many visits as the two highest regions, but they have a lot more people and a lot less facilities. So percentage-wise, we have visited the overwhelming majority of our facilities.
Are there any questions on these graphs and this information? Any questions at all? You like what we do? Yeah, we keep doing it, right, Dr. Silvernail?
Got a question here?
Okay.
Yes, sir. Yes, ma'am.
I have a few. So when you make these recommendations, are the facilities required to adhere to them? And if so, to whom do you report these gaps that you find?
So we report the gaps back to the RIPS team, and the RIPS team basically collects local data. They collect regional data on the gaps that are in facilities, throughout an entire region. So they'll see that maybe our region has less gaps or more gaps than other regions in certain areas, and they're kind of interested in that data, but they're just interested in seeing what gaps there are generally. Now, as to whether or not they're required to implement them, when we make recommendations to facilities, we are providing them guidance. They're not necessarily required to implement our recommendations, but some of our recommendations cover things that are required. Like, for example, OSHA requires employers, particularly in like nursing homes, assisted living facilities, to implement respiratory protection programs. So like have their staff fit tested and medically evaluated to wear N95s if they're managing COVID cases. And that is a requirement through OSHA, but through us, we recommend to them, and we basically show them that guidance, that this is kind of expected of them as a facility. But from our perspective, it's strongly encouraged because it promotes good infection prevention.
To add on to that, that's one of the things that the state program is looking into, is making us part of some mandatory program so that we can enforce these gaps that we see, but we can't enforce it, that they do them. One of the things we're having in our conversations with the state is what program can we be under? Can we be on the DHSR or the DHSS, that this can continue on from here going forward? This program was put into place, and it's something I tell everybody, and I don't mind saying it should have been in place 40 years ago. Because we've always had a gap with the nursing homes. They are our most vulnerable population of people. So when COVID hit, they saw that. They were the most, death and mortality and morbidity associated with that population. So if they can make us mandatory, these gaps will have, as he said, we recommend compliance now. We want to get to the place where we demand compliance to close these gaps so we can make us safer, healthier North Carolina.
But we are bringing to their attention a lot of things that they are completely unaware of. When we go into an assisted living facility that has 100 residents, they sometimes just completely don't know about the expectations from the CDC. They don't necessarily closely follow the guidelines of the CDC. So when they bring one of us in, we basically show them the light. This is what has been expected of you all this time. This is what we recommend to improve your infection prevention practices, to prevent a whole bunch of people at your facility from getting sick. That benefits them, it benefits their residents, it benefits your community. It's a win-win-win situation. As long as they take us in, we can provide that good information for them and help them stop a whole bunch of bad things from happening.
Thank you. So you guys have provided some great information. I appreciate all
Thank
the
you.
information you shared. Great presentation. Last question. How often do you guys get around to visiting
I
those
visited
facilities?
a place today. We have conducted over 230, I think, visits.
I guess what I'm asking is how often do you get back to those same facilities?
Often. We've conducted, I want to say, roughly 100 follow-up visits.
Okay.
And about 130 initial visits, if I recall correctly. Many follow-up visits. Some facilities we've been to 3 times. We'll visit them during an outbreak. We will help them control that outbreak. We'll make sure that they are implementing every precaution that they can to prevent the spread to additional residents. It really helps to have an extra set of eyes in a facility when an outbreak is going on. And we're kind of used to it, but to a facility that's never had an outbreak before, it's kind of like pandemonium. But when you're used to it and you can step in and you can help them out, that means a lot to them. And it definitely kind of opens their eyes to anything that they're missing. They get guidance from their local health departments, and we try to go above and beyond. And we make sure that their local health department's guidance to them is as sound as it can be. And anything that they're missing, any misconnections between their local health department, we try to cover those too.
Because we reach back out to them over and over again, especially when we identify gaps. We'll reach back out and say, can we make a visit? But again, we're not mandatory, so they can deny. We have got I would say about 10 of the 240 facilities, about 10 or 12 that refuse a visit from us. They just refuse it because we're not mandatory. We said we can come in and assist you. We try to placate them and saying, you know, we can assist you. We can do things that the state's going to look for. We can get there before them and help you get this in place. Then you won't get a thing from the state. But that doesn't sway them a lot of times. But we're always available. We call every day. We just get on the phone. We spend quite a bit of time on the phone.
Dr. Herr?
Okay, Dr. Helm.
So thank y'all for doing this. I had a question about outbreaks. So I'm glad to hear you respond to outbreaks, but how do you get that signal? How do you know when a particular place is having an outbreak, and then
The
do
state
you
sends
call them
us a
immediately?
list. The state sends us a situation report the night before or the day of. They send us a list and say.
So the state Department of Health lets you know about it?
Yes, sir, the DHHS will basically they'll get reports of, like COVID cases from facilities, and they'll immediately send out to our team, this facility has this many staff members or this many residents positive. And, we'll respond to that, particularly ones that, you know, obviously if you have a big outbreak, we respond to that quickly. There have been some times where, you know, I'll see it that day, I'll call up the facility and tell them, you know, I can be there tomorrow if you want, yes. And we'll head right out and get to that facility and provide that guidance before the outbreak continues to spread to everyone.
We have also gotten calls from the health department, the local health department, Carteret, Pitt, you know, Jones, whatever, Craven, Green. We get calls from those as well to let us know. Because that's what we do. That's what we're here for. Okay, any more questions?
Once there's an outbreak been identified and the state's made aware of it, can the state then require the facility to let you guys come in at that point?
At this point, no, that's what we're looking for. We're looking for that mandatory requirement from the state. And that's part of what this program hopefully will evolve into. But the state can call them and tell them about us, but it's still up to them whether they let us in or not.
Now, I mean, there are programs within the state that can always mandatorily visit, but we've noticed that those programs, they're not really focused on infection control. You know, they're focused on a lot of other things. They'll focus strictly on patients' rights, or they'll focus on meal plans or things like that. Whereas we just focus on preventing and controlling outbreaks. And, yeah, just infections in general.
When you make first contact with a facility and you diagnose there needs to be follow-up done, how long before you'll go back? Is it weeks or a couple months, or what's the normal follow-up?
Yes, sir. So because we cover 250 or so facilities, we try to aim for follow-up every 6 months roughly.
Yeah.
But it depends. I mean, if we have an outbreak, we'll follow up even if we were there 2 weeks ago. So it depends on their circumstances. If they were to call us even 2 weeks later and say that they want us to come in and evaluate changes that they've made, that's something we would do too. Basically, anytime they're willing to have us in is a time we would go to their facility and work with them.
Awesome.
Yes.
Thank you guys a lot. That was a good presentation. Any other questions? Very good. Thank you again. Y'all have a good evening.
Thank
too.
you all very much.
Thank you.
All right.
Thank you for coming, guys.
Appreciate it.
Next up, we'll have our annual report from the Child Fatality Prevention Team.
All right, good evening.
Good evening.
I'm Jennifer Hardy. I'm the coordinator of Women's and Children's Health Education Programs with the Health Department, and I help to coordinate the Child Fatality Prevention Team. And so I'll start out with a little introduction in case anyone doesn't know or you need a reminder. The North Carolina Child Fatality System was established by legislative decree in 1991. The NC Child Fatality Task Force was also established in 1991. The NC Child Fatality Prevention Team, the state team, was established in 1992, and then local teams were established in 1993, so we have one team per county. What does the CFPT do for the state of North Carolina? Helps to promote understanding of the causes of child deaths, helps to identify deficiencies in the service delivery to children and families by public agencies, helps to assess, recommend, and implement systems for change that will prevent future child deaths, and support safe and healthy development of our children. The CFPT includes appointed representatives of public agencies, non-public agencies, and also the community. For our local child fatality prevention team here in Pitt County, the chair is going to be Dr. Silvernail. Co-chair is myself, and then our review coordinator is Portia Mizell, and she actually is the one that makes all the magic happen and keeps us straight. She's fabulous. Other team members includes DSS director or representative, DSS staff member, DSS board member, law enforcement office, the DA's office, community action agency, schools, mental health, guardian ad litem, healthcare provider, health director, representative, EMS firefighter, district court judge, medical examiner, child care or Head Start representative, parent, or other members appointed by the county commissioners. The full child fatality prevention team meets quarterly, and the subcommittee also meets quarterly. So what happens is we meet with the subcommittee the month before the full team meets. So that would mean that in January we meet, review the cases, and select the ones that we will review for February. The CFPT has statutory access to records of birth and death certificates, medical facilities, the Department of Social Services, courts, law enforcement agencies, the school system, and then outcomes of services and circumstances surrounding the child's death. The main goal of the child fatality prevention team is to review child deaths and to study ways to prevent child fatalities. So other purposes are to identify deficiencies in the delivery of services to children and families by public agencies, make and carry out recommendations for changes that may prevent future child deaths, and then also promote understanding of the causes of child deaths and advocate for children. So in 2020, there were 45 child deaths that we received notification of. The Child Fatality Prevention Team Subcommittee chose to review 5 of those cases. And there were also a few other cases that we would have selected, but we did not. 4 of those were pending criminal investigation, so we cannot do those until they are tried and the case is cleared. And then another one was selected by DSS to undergo an intensive review, so it had already been reviewed thoroughly. But most of the deaths that we saw during this time were related to prematurity or birth defects. So system problems are existing policies, rules, or gaps in services that might contribute to child deaths identified were unsafe sleep conditions still continue to be an issue, probably more than the year before. So actions to be taken with that are to continue to promote the Cribs for Kids program in the community and to offer regular educational sessions for access to pack and plays and safe sleep information. Also, paid media to promote the program. We also promote safe sleep at community events, health fairs, and things like that to reach those who may not qualify for the Cribs for Kids program, but we can still give them safe sleep information. But for the program, there are some criteria. You have to be a Pitt County resident, you have to be pregnant or have a child that is under 12 months of age, and then also be receiving public assistance, so WIC, food stamps, or Medicaid. Also, what has kind of come out of some of our review, this is not our program, but this is from, it's hard to say ECU Health, that's new, ECU Health, the Injury Prevention Program. And so it's the Pitt County Firearms Coalition. It's pretty new. Sue Ann Pilgreen is the manager there. And she and our medical examiner who serves on our team, Dr. Kelly, expressed concern for a number of months about the number of firearms related deaths or things you see in the news related to firearms, and so started to do more research on a firearms prevention coalition, and so they did start one, and that is up and running. So the purpose of that coalition is it is a nonpartisan, apolitical, multi-sector coalition aimed at the reduction of injury and death from firearm violence using public health strategies through the identification of solutions and impactful interventions. And the mission is to reduce death and injury related to firearms through broad-based and preventive strategies to promote a safe and violence-free environment. And their vision is a community where every citizen feels safe from firearm violence. And also, the coalition received a comprehensive suicide prevention grant. Funding started March of last month, and their focus is going to be on LGBTQ plus youth and veterans. And then also firearm safety education and gun lock distribution is something that they're going to focus on. So that was born from 2 of our members. And that's all I have. Any questions?
When child is described as a person under age 18?
Yes,
Okay.
18 and under.
Kelly?
So you said there were 45 deaths in 2020, and most were due to prematurity.
Mhm.
What is most? Give me a number if you happen to know,
Let me think.
or a percentage.
I'm trying to pull out. Probably 85%.
Okay.
That's a good guess. And that number seems to be up from the previous year. So, which we saw an increase in our infant mortality rate as well.
Sure. And you guys don't do any specific drill down into those numbers? Does that rest with a different team to investigate?
I do that as well with PIMPAC, which is the Pitt Infant Mortality Prevention Advisory Council.
Yeah.
And I have a separate presentation if you're interested.
Always interested in that.
Okay.
Thank you.
Any other questions, comments? Any firearm questions, Dr. Garrison?
Well, so it's thrilling for me to see the Eastern Carolina Injury Prevention Program doing this work. I was there at the beginning of it 20 some odd years ago, and it's tough to be apolitical in something that's very political. And but if you're going to focus on something, teen suicide is right there to be at, and it is the most tragic thing to see one of these deaths. So I'm so glad y'all are working on this.
And I serve on that with them, but Sue Ann's in charge and doing a great job.
Great.
Awesome.
Thank you.
Thank you. Have a good evening.
Thanks.
Thank you, Jennifer.
Next, we'll move on to the Health Director's Report with Dr. Silvernail.
Dr. Harrell, if it please the chair, 2 of my nursing supervisors are here. They had wanted to address you in public comments. I know it's out of order, but would you be
Sure.
willing to consider that? Ladies, did you want to, or lady?
You have the floor.
Good evening.
Hello.
So we were just basically going to try to touch on the ARPA funding, try to see what you guys' thoughts were. I know that the county commissioners have had several people come before them over the past month and a half or so.
I'm going to interrupt you real quick. Can
go
you
ahead.
introduce yourselves,
Oh,
please?
I'm sorry. Yep. I'm Jessica Hardy. I am the Women's Health Nursing Supervisor. Yeah. Sorry, it just changed. We got a new supervisor, so some of my stuff went to her. So I have to get that right.
And I'm Lee Cutler. I'm the Communicable Disease Supervisor.
So over the past month and a half, we've had several community members as well as partners that we have had at the health department with us throughout COVID come before the county commissioners and plead with them to reconsider their awarding of ARPA funding to the original call, or the original, I guess, plan when it first came out and we were first notified that we would be getting ARPA funding was to utilize that for what they were calling premium pay. So we had thought that that was going to happen, and then the county commissioners had said no. We gave the $1,500 for that, and then I guess we just were wanting to, I know I've talked to Dr. McIntosh several times back and forth, and we were kind of wanting to get your thoughts on what you would like to see happen with that ARPA funding as it in regards to the health department. Just because we have had so many staff turnovers just because of the sheer volume of things that we have to take care of with COVID, and then on top of that, doing our normal duties as well. And I don't know if you want to speak to that since you're CD.
I mean, it's just been, you know, the past, I guess, what, 2.5 years now, I think you lose track of time. It all just seems so, I mean, the amount of work that we all put in, you know, going to work every day, which is our job, but it was just, you know, compounded by a pandemic. Again, we still had all of our other work to do. We had, you know, we're still talking about the staffing shortage. None of that changed. It probably got worse during the pandemic. And it definitely got worse on the days when people got sick or had to go home and quarantine. So that just left a few staff there. So it was just, and that was every day. Every day. I mean, Monday through Friday. I know I came in on the weekends and worked, trying to keep up with just the sheer volume of the reports coming in. Because outside of the patient care, the face-to-face with them, whether it was doing COVID testing or, you know, giving vaccines, then you have the paperwork and the reporting. You know, Dolores and the other fellow were in here. We had one other person who was our CD coordinator at the time. She was the liaison for the long-term care facilities. If I had a dime for every time we referred one of those people to Dolores, I wouldn't need to work. So we're very thankful that that started for us. I mean, they helped us tremendously. And then I was the school health liaison. So, you know, fielding phone calls from school nurses every day, multiple, could be 50 calls a day, trying to check on results of COVID tests for kids, because people couldn't get it. And again, when we found out about the ARPA funding, I think we were under the impression from what we had heard that there was going to be hazard pay, there was going to be premium pay. Well, the premium pay, I guess, came out across the board for everybody, across county government. Whether you worked from home, whether you worked in the building, whether you worked in public health, it doesn't matter. And then once that happened, there was no more talk of hazard pay. But we're still familiar that this is here, that I don't know what it's been, if it's been already earmarked for something else, I have no idea. But we did ask, you know, wanting to come to the Board of Health for you all to be able to support us. Just because we didn't really feel like we were able to, I guess, go to bat for ourselves. I mean, we were just in a precarious position. So, and I know Jessica did a lot of talking with different members, whether it was with county commissioners or with some of the Board of Health. So, and I know that the last conversation was that, yes, people felt like we were deserving of something and that they were going to address the commissioners. And so we were, you know, one, has that happened? And I guess what came of it? I mean, are we at a stalemate, or are we?
Well, I can answer your first question. We are constructing a letter to be presented to the Board of County Commissioners. That's not been finalized, but that is in the works. We talked about that last month at our April meeting. That is your first question.
Right.
I don't know if you guys are aware, but so the last county commissioners meeting, I guess they called me after the fact because I had been at every county commissioners meeting for the past 4 or 5 meetings. And I spoke at the last one, and Brian Barnett called the next morning and was just kind of saying, hey, I just wanted to let you guys know that the county commissioners are not going to talk if you guys are presenting during the public comments. And I kind of said, yeah, we were aware. That's kind of why we did the public comments, because we wanted them to hear our voices and to know that this is a concern of not only us. I mean, we're not even, you could pay me or not pay me. You know, my staff were out there on the curb in 110, 115 degree index, swabbing people in full PPE, about to have medical emergencies. I mean, I'm fighting for them. I was on maternity leave for 3 months, so I didn't even get the brunt of it, but my staff did, and I can tell it in their faces. And I guess that's what I'm more passionate about, is I want to speak for my staff. And right now they're feeling beat down. They're feeling like not seen, not heard. Public health has always, I guess, kind of been the unsung heroes of the healthcare community, just because we do our work quietly, we keep our heads down, we try our best to mitigate circumstances where outbreaks do happen, but we're not funded very well to get the front page. Like I think one of our nursing contractor workers who has been doing vaccines with us since we started said, you're not going to see public health's face on a poster or a magazine. We don't have that kind of publicity or funding. It's not a pretty job, but we did it, and we did it willingly because we knew that if we didn't, our community would fail and our community would suffer. And I think with the whole $1,500, yeah, that was great. We're not saying that that was not appreciated at all, but no one felt that we were put at a step above because of the work that we did. Everybody got that. So you could be sitting at home for, like she said, for 6 months, doing your work from home, not being at increased risk, and you got the same $1,500 that somebody who stood out there in full PPE testing people at the car side for 6 hours got. And I feel for them, and I know that they feel like it's not fair, and I agree.
What do y'all think is a fair response?
So,
How does this play out in y'all's head, I guess is my question.
I'm too short for this. So Brian Barnett, like I was saying, he called me the day after, and he was basically saying that the plan is to have policies. They have about 10 policies, he said, that have to be written before they can even start determining what they're going to do with the ARPA funds. And it would basically work as a grant application, per se, where they would have certain pots of money set aside for certain things, and then the facilities or the entities would apply for that funding. And he said that, well, premium pay, hazard pay would be one of the easier things to award money for because there's not as many hoops to jump through, according to what the federal government has laid out. So he has encouraged us to formulate a proposal so that when that application cycle, which he was projecting mid-June to early July, opening that application cycle, to have a tangible plan or something formula-based or numbers to give them rather than just coming forward and saying, hey, we think we deserve something. Having something tangible for them to look out and say yes or no, or let's decrease it by this much, let's increase it by this. So we were wanting to get with you guys to kind of, I guess, brainstorm from your standpoint in your roles what you felt would be something that we could ask for. Because we really don't know. I mean, we just work at the health department.
Not necessarily the monetary amount per se, but more of like, what do you all think would be a good formula to work with? And, you know, whether you've done these type formulas for
Right.
some other type structure programs.
And I didn't want to necessarily, for it to be a one-time thing, it would probably behoove us to have some sort of retention type plan that goes along with this. So not only are you recognizing the people who did go out and do all the things that we needed them to do, but you're keeping them instead of letting them go. Because if we have another pandemic and all of our staff are gone, it's going to be me and Lee.
You know, just going back to the positions open, our communicable disease coordinator position's been open for, I don't know how long.
Year and a half.
And kind of, we all kind of shuffle between the same, communicable disease positions, whether it's TB, regular communicable disease. I'm the communicable disease supervisor. I'm still covering TB. The TB coordinator moved to the CD position. However, she's one of our enhanced role nurses, so she's still having to be used in clinic to do STD screens, which are, I mean,
Every day.
every day.
All day.
You know, our STD coordinator, thank goodness she's still there. She's on vacation this week, so we're filling in for that too. But I mean, just in this day and age, kind of going back to public health, I mean, where it's the unsung hero in a sense of, I mean, I don't know, maybe we're special people that, you know, like working in public health. I have no idea. But it's all I've ever known is public health. But to not even get any applications, or, I mean, I don't know if it's because of people shy away from it now because of the pandemic, but I don't see, I mean, this has been a long-term problem filling these positions. So you know, again, we're stuck with, there's a few core group that knows communicable disease at the health department. And if one more person walks out with that knowledge that knows how to do it, I mean, then it's just, again, it falls on the people that are left there. I mean, it's an overwhelming amount of work. Which we want to
Can I
try to
ask you a
do
question?
because, I mean, you're protecting the community. I mean, nobody wants TB to get out of hand. I mean, people forgot about TB and things like that when COVID happened.
Dr. Garrison?
Yes, sir.
So have y'all looked at what other counties or health districts are doing? Have you found one where you said, golly, yeah, that's what we have in mind? Have you found anything like that?
You mean as far as like a strategy that they've utilized?
Yeah.
I know we've come across some articles where other counties, and I can't remember,
Wake.
Dr. Hardy, you may know what some of these counties are, I just don't know them off the top of my head, where they've used ARPA funding for different things. What their structure was or formula was, I don't know. I don't know that it was published anywhere.
Good evening. It has been published. Mostly the information that we have obtained has been in the news, in news articles online. So Raleigh, Wake County, the framing of the funding is a little bit different. It may be retention, it may be hazard, but Wake County gave their employees, 4,500 employees, they gave them a range of $3,500 to $4,000, depending on how much the employee made. They made their first payment in March, the next one in August, and the next one in December.
This is for employees of the health department.
Actually, it was countywide, actually. This approach was countywide. In Craven County, their commissioners gave their employees a 2% raise in July, and then they went back and did an analysis of surrounding counties and increased that funding to a 5% increase in December.
This was for the health department.
That was for the health department.
Yeah.
This may be a little bit of an outlier. Transylvania County gave, and Macon? I know Transylvania County particularly reported that they gave all of their public health nurses $25,000. I don't know any further detail about that, but I'm just answering the question.
That was the maximum amount of what the ARPA funds
That was
said
a
that would
max,
allow,
yeah.
given per person.
There are other counties that have done similarly. Some counties gave a 12% increase, but that was to EMS. So the strategies and approaches are varied. The Sheriff's Department, Public Health, and EMS were specifically noted in the ARPA funding document. But those are the things that I can recall off the top of my head, that I can recall.
How much is the ARPA? How much does Pitt County have?
I believe we received 37.
35 million, I believe was the
In
number.
half, we got some,
We got some last year, and then we got the remaining half will be either coming this year or we got it this year.
I think it comes this month.
Yeah, I think it's-
And those dollars are only given to the county, not the city.
The city got their own funds.
Separate
City of Greenville
two
got
separate.
ARPA funding, school district got some ARPA funding.
Just to make sure I understand, so there's a big chunk of money. So far, every county employee has gotten $1,500. Is that right?
That's correct.
And they're going to put some grant program together where a county department can apply for more funds. Is that
Correct.
to be distributed?
Yeah, and the $1,500, I believe, did come out of the ARPA funding, if I'm not mistaken. Yeah.
May I just add one quick comment? I want to make sure that we're heard clearly. We are not asking only for nursing. We could not have done what we accomplished in the pandemic with the vaccinations, with the testing. We could not have accomplished those things without the support of the other health department employees. We've already referenced some of the staff that work with other programs. We we did this work before work and before the usual 8 o'clock. And I think we're all saying that we're not asking for anything other than what has been deemed would be appropriate. I think when you calculated the rate, it was it $1 extra
So
a day?
if you, and I calculated this just for myself in the hours that I worked. So I actually looked at my personal time, and with 3 months of maternity leave taken, the $1,500 would have equaled out to 43 cents per hour that I worked. And that was up until the beginning of April, I believe. So, all the other staff who were there when I was not there, they had 3 extra additional months of work that they worked 8 to 5, after 5, before 8, on the weekends. So it was just, I didn't get to make this point at the commissioners because I didn't want to make them mad, but it was less than a postage stamp a day, or an hour that we were reimbursed for shouldering the brunt of the pandemic and the testing. And I don't know if you guys remember, in the very beginning, we were shooting them on through like they were nothing, and Vidant had a 6 to 7 hour wait. So we did the work. We just want to be recognized for it. And that's everybody at the health department that did an integral part to making sure that health department stood, and we continued to be able to do the services for the patients, as well as provide the additional services that we were asked to do for COVID.
If you had a magic wand and you could direct the county commissioners to do whatever you wanted them to do, what do you think would be a reasonable thing to recognize and honor I'm not sure it's just public health, because you mentioned the
No.
sheriff's department and EMS. Lots of other people were involved in the pandemic, but what do you think would be a good way to honor what these people have sacrificed and done?
In this day and age, my generation, we like money. It's sad to say. Yes, a pat on the back and a thank you and we really appreciate the great job that you've done. That's great, but my personal journey, I gave birth 5 weeks early. And then as soon as I came off of maternity leave, I was right back out there in the face of COVID, risking bringing that to my child, risking myself getting it, because at that point, we didn't have a vaccine. There was nothing we could do except for wear the PPE and hope to God that we did not get in the face of someone who coughed on us or sneezed on us when we stuck the swab halfway to their brain. It's hard to place a monetary amount and say that that's good enough.
What would be good, though?
So, it would be great to get $25,000 apiece. However, we realize that that's probably not going to happen. Something more along the lines of maybe like something similar to what Wake County did, where they gave a check,
A set amount.
and then if you stayed, 3 months later you get another one. If you stayed, 3 months later you get another one. Something to keep them here, because we do want to retain our staff. That's another problem we're having, is the retention of staff. We're underpaid. We've been underpaid. And we're competing with Vidant, ECU, Physicians East, private doctors' offices, and they're just paying more. And we can't help that. But if we offer some sort of incentive to stay, hopefully we can retain those staff to the point where they have a vested interest in us, and not, as I hate to say it, but my generation will go to the highest bidder. And I was raised by baby boomers, so I'm different. But yeah, I think that something that is more of a timeline of events to kind of make it more of a hazard pay bonus, but retention strategy for the people who did work through COVID, so that we keep them.
Can I
Go ahead.
Quickly. My concerns are two, stability of the workforce. We just lost another nurse who will be leaving at the end of this month, which is, actually, she was one of the nurses that we onboarded during the pandemic. If any of you have onboarded anybody during the pandemic, you understand that that experience probably has not been ideal for the person who you onboard. These ladies that are standing beside me and the ones that you actually cannot, who are not represented here today, have worked and worked tirelessly to complete their job and the jobs of the people who were not standing beside him for the vacancies that we're not able to fill. That's my biggest concern. So when you talk about a strategy, I agree. I liked Wake County's approach. They had it to where it was at intervals, and it was based on pay. So, and let me clarify that. The people who made the most money got the least amount of bonus. I like that. We have employees in our agency who were out of the workforce, and Dr. Silvernail can attest to this. He knows it better than I do. They were on quarantine. They had to be out of the office for 14 days sometimes, repetitively.
Or their kids.
With their children or with their spouse or because of exposures. Actually, exposures in the workplace. We had that a lot initially. These people ran through their their sick leave time, and some of them have not recovered financially yet. It's easier for those of us who make a little more money to think this is not important. When I look at our workforce and I look at I don't know the specific data in terms of what they make, but I know that many of our employees do not make a lot of money, and they are on public assistance. They have not recovered from what they did to come to work every day when they were allowed to be in the workplace. They haven't recovered from that yet. Some of them haven't recovered in the sense of really not feeling valued for all that they did contribute. And when I say they contributed, they got up early. They were at the sites before anybody else was, or at the health department, to make sure that our supplies were there for us so that when we got there, we could get in the van and we could go. And I say we, but I was oftentimes at the site with the sheriffs. I would meet them there to sit at the site. But they have a different perception, and they're actually our younger population. They have the experience of working in a pandemic, and I think it just behooves us to try to retain those, not that we ever want to have one again, but they are familiar with what it took, the structure in our staffing, the structure in having teams preparing the supplies and having a team to order PPE and having a team to do the many different tasks that we had to have. We have a young workforce who has that experience. There are those who are like me who are at the door of retirement who, we're not your focus. I'm not your focus. It's your younger people who need to be your focus. We need to keep them. We really need to keep them. Thank you. I'm going to sit down now.
Thank you, Dr. Orr.
And I'm just going to piggyback on that too. We do yearly trainings with emergency preparedness. So we do, we used to before COVID, where we would go and set up pods and kind of practice through what that would look like. That does not prepare you for something like COVID. That prepares you for an anthrax attack or something that is known that we know how to fix this. We didn't know anything about COVID. We still hardly know very much. I mean, it changes from day to day, the guidance that comes down. And I think the unknown, again, was a little bit more than what it was made out to be in the media. The people working it were just kind of like, oh, well, we're just going to go and we're going to do all this stuff. But we don't really know the ramifications until years later of what that means.
Do you know what the maximum amount that a Wake County employee got over what time period?
4,000.
4,000.
Was that 4,000 in three different bunches or 4,000 divided over three? 4,000 total or 12,000 total?
4,000 total.
And I think we have to be careful about we're having two different conversations here.
Right.
We're having one conversation about COVID reimbursement, I'm gonna call it, or hazard pay, and then retention and underpayment and those things.
Right.
We had to be very specific about what we're gonna say, because what I was gonna say to you earlier was, we've been having this conversation for a long time, and a lot of this stuff is not in our wheelhouse or in our realm, because this is at the state level. These are things that have been petitioned to death. So we have to be very specific about what we're talking about, not you can't look at the big picture with this. You have
Oh,
to
yeah,
be
yeah.
very dialed in on what we're asking.
Let me clarify. Some of those counties that we were mentioning that use funds, they either used ARPA funds to give the bonuses, or they went into fund balance. So they used two different pockets of money, but they still used the term retention, even though they were using ARPA funds, because their vacancy rate was at an all-time high, and they were trying to hold on to the workforce that was currently in positions. So they actually interchangeably use the terms
Right.
retention, so that's why I use that term.
Okay. Commissioner Albright, do you have anything from the
I think
Commissioner's
that having a
standpoint?
plan to go to, that is organized and presents, what it is in real dollars, per, if you're doing it by hours. I mean, I think that one of the issues is certainly, how do you it is across the board in some ways. I mean, it's very difficult to say to one department, you're not as valuable as this other department. First responders are identified already in a different way, and I think if you concentrate on that aspect of it, but then within that, are you going to break it down, and that's would maybe be what y'all want to think about. Is it per hours? Does someone who took 3 months off get less? How are you going to, what is it you're going to propose? And is that per employee, and how much money are you asking out of this pot? And I believe that there's one pot that is designated for this kind of expenditure as opposed to, facilities and other things. But I think that's important, and it sounds like your conversation with Brian would indicate that you would maybe want to have something communicated to the county, pretty soon.
Commissioner, are you saying that the more detailed the request?
I don't mean detailed, but I think specific. If you're saying we want more money,
Right, in general, like that.
how many people are you talking about? Are you talking about rewarding people that have been hired now? I mean, how do you set the parameters for who did the work, who, I hate to say it, but it sounds like suffered the most?
Right.
And there was a lot of suffering, and it's unrecognized. And so people that don't know that have to be told it in a way that only y'all can tell it. So if, Dr. Hardy is saying, concentrate on what population in your employment do you want to most reward, and figure out a way to say they were doing these jobs and therefore they should get this percentage, or go with split the money with everybody, and then it kind of dilutes it, it seems to me, as opposed to targeting it, which maybe is a little more difficult. But I don't think the specifics, you don't want to get bogged down in those, I don't think. But somehow becoming comfortable with the distinctions that you're making. And I'm not hearing, it sounds to me like that's a difficult thing to wrestle with.
It is.
Could someone on your staff, could y'all have a subcommittee? Who could come up with this? I mean, the county commissioners can't, because we don't
Right.
know.
Yeah, and
We're going to try to treat everybody the same and
Right,
make everybody
right.
happy, and nobody's going to be happy. So.
Right. And I've wrestled with ideas of how to appropriately delve this out. Hours was one way to do it, but unfortunately with our time and tear system and all the confusion of COVID, nobody was coding correctly because all these different codes were coming out at the same time that we were having all this other COVID stuff happening, so we were coding to the wrong code. It was still direct patient care, but we weren't coding it to COVID. So using the COVID code, I think, is out, in my opinion, just because of the sheer confusion behind.
But see, y'all have to come up with, I mean.
Right.
Somebody's got to do this.
Right.
And I think that, this board would be the conduit, but y'all are the ones that are on the line and could say, if you're already working on the letter, it seems like it's almost a fill in some blanks here, and we need some specifics, but not too many details.
That's the point I was trying to make, is bring the commission a solution.
Yeah.
Right.
Here's the
Yes.
problem.
And
but
we
bring
all know how bad, I mean, I don't know, I shouldn't say we know how bad. We have heard that it's really bad, and we do feel for that, and we wish that there were ways to help that out better.
No, I mean, I think we need to work that, because that's what we'll do on our end, is come up with some type of formula or algorithm or whatever it might be to have a better plan,
Yeah.
to give to you all to be able to
Yeah.
put
Or-
forward.
Yeah, I
Is there-
would say that I don't think that having it staggered necessarily, it complicates it too much from my point of view.
Right.
It would possibly even free up more money in the end. I don't know, but if you're trying to spend the money and you it's like payments, and you can drag them out a little, but it
Right.
still is designated as hazard pay for what y'all went through
Right.
during COVID. And so we're just saying, instead of paying it all off at once, we're gonna pay a little bit now and then a little bit more. And it still isn't very much, it doesn't sound like.
So, I guess my only question for you guys, is there a specific time frame that you want us to look at for employees? Because obviously, somebody that started yesterday, I don't know if because I know that the CDC declared the pandemic over 2 weeks ago? I think it was 2 weeks ago.
They did?
Mm-hmm.
I hadn't seen that one, okay.
Keep it quiet.
Yeah, they didn't advertise it very often, but, so I don't know if you want us to start looking at from the time that, like, I know Dr. Silvernail, announced our first case was maybe March 17th of.
March 19th.
19th of 2020. From that date until a certain date, all of those workers are eligible, or, because I can come up with some numbers. I wanted to get your guidance, because you are our governing board, to kind of give me a starting point.
So I like the March 19th date, but I can't tell you what the end date needs to be.
Okay.
We might would
Right,
need to do that
right,
ourselves, because
exactly.
we know what we were doing and when we were doing it.
Yeah.
So, 'cause,
And we
at
would-
some point, we stopped testing at the health department for the most part, and, mass amounts of people, and so I think that would just be us to.
And you guys would have to tell us who was patient-facing versus
Right.
at home, whether it was quarantine or not, but home, and not having to be in front of patients and taking care,
Right.
we would need that kind of detail as well.
Okay.
And we'd also kind of need to know how much we had to work with, I guess. Right, before you
Okay.
plug in a number, we kind of need to know what the.
What the total amount
Yeah,
of.
what the denominator is.
Okay.
People and amount of money, right? 'Cause you can
Gotcha.
come up
I
with.
don't know what the amount of money is.
Well, I
don't
wasn't
know
saying
what
that,
they've got.
that's why I kind of looked this
Right,
way.
okay.
That's
But-
gonna
but
be
that's-
hard in the end, because if you have, I don't know what it's gonna be, $12 million, say, for this, and you're trying to divide it out over sheriff, and, I don't know. That might be a question that Brian could answer, if you have an amount, but I don't think that's been legislated. It's a very good question.
Yeah, it didn't sound like they had a set amount.
I think that asking for something that would be close to satisfactory,
Right.
and then if
We can back
it looks
into
like
it.
we don't have the money, then
Yeah.
we say, well, that looks good, but it could be
Yeah,
funded
it-
possibly at this level.
These are the people that we think have sacrificed and deserve it. And this is the types, and then this is how many they are, and this is the amount. Now you've got a big number. Well, do we have that number? And if
Right.
not, what do we have? And then it becomes a negotiation. But I think having something down on paper to bring us, here's a proposed solution, is always a good way to start a conversation.
Yeah. And I have some sketched out ideas, so I'd be willing to,
Another thing I would look at with you're speaking about the time, and we got a start time, but what's our stop time? And
So I
so
think
I would
that-
say, and y'all expand on this, the testing and the vax clinics. And there's got to be somewhere around one of those times is when our stop time is.
Yeah, so I mean, I'll probably defer to Dr. Silvernail, because he knows the numbers more than I do, about the, I guess, infectivity or contractability of COVID during certain times, like when we reached a certain point of everybody being vaccinated. And that would, I guess, help us kind of narrow down a time frame of when the most hazardous conditions occurred. You know, with no vaccine, we didn't know, our staff weren't fully vaccinated or considered fully vaccinated. Most of the population wasn't fully vaccinated yet. But we can probably get with Dr. Silvernail about that.
Based on that, we're looking at probably 12 to 14 months.
Yeah, testing ran until, I think it was December 16th or 17th of 2020. And then we started vaccinations on December 23rd. And our big clinics lasted until the end of March, I think, of 2021.
So
That's
that's
probably when we did our
12
last
months.
March or early April was our last big public clinic.
And those were second doses, right?
Yeah.
Okay.
Yeah, and we had one big J&J clinic in there too, where we did.
Right, yep, I remember that, yeah.
Yeah.
That was in March.
Mhm.
So, yeah, so just so we all have the knowledge, we'll come up with that.
Time frame.
Timeline, events, and
Another
who's doing
thing
what, and-
to add is that Dr. McIntosh and Tina were spearheading the letter to the commissioners, and obviously neither are here tonight, so that's why I can't give you more information on that. But I know it's being worked on.
As long as we know it's still in the works, and that gives us hope.
No, it is.
So,
Thank
still
you
out on the
both.
table.
Other questions or comments from you guys? Thank you both for being
Thank
here.
you for all you do.
You
Thank
bet.
you.
On to Dr. Silvernail with the health director report.
Get my old bones out of this chair. Great. Thank you for hearing my staff out, Dr. Harrell. Good evening, folks. Wanted to run through some things with you this evening. There we go. We remain in the eye of the storm. I got the Truckee version of that up. Ladder 132 out of Harlem. Great shirt, my good luck shirt for exams and things like that. And darn fun to take those irons and swing them around at something. Jump right in. I want to review some of the COVID data with you. This is out of, I guess I can say ECU Health. I almost said Vidant when I was putting this together, and I said, no, I guess it's official. I can say ECU Health. So this is the sequencing program that comes out of the Vidant Clinical Services run through Dr. Fallon's lab. If you look over to the far right end of that graph, the sort of orange color is Omicron. You can see how fast Omicron replaced Delta. And then if you look at the sort of the charcoal gray color is the Omicron BA2 and how fast BA2 has supplanted BA1. And when we look at those numbers, right now BA2 is 99.4% of the sequence sample, so very, very rapid replacement of BA1. There is talk of BA4, 5, and something called BA2.12 out there. Those are all believed to be more transmissible than BA2 and may at some point displace BA2 as the predominant strain. Here's our Pitt County epidemic curve. I think pretty clearly 1, 2, 3, 4, 5 waves already, if you count the ECU wave in there. And we're in the beginning, the upslope of our spring wave for this year. This is, the state is not reporting day to day anymore. This is week to week. So this goes Saturday to Saturday. So that last column on there is from this previous Saturday, this past week. I can't even think of what day it was now, the date. COVID-19, this is our epidemic curve by age. Again, if you look at that, you see the bulk of that, that last column is the red, remains that 25 to 49-year-old age group. So we've seen some uptick in cases, but not as big as other waves that we've had. And generally in the spring, we see a spring wave. In the pre-COVID era, we saw a spring wave of influenza, typically flu B, if you look back at old flu surveillance. In the COVID era, we've seen that spring wave again. And this year, we had a lineup of the three of the big religious holidays in April. Ramadan started on April 2nd. Good Friday and the first day of Passover were the same day on April 15th. And then throw in some spring break in there for the college and the public schools and other schools. We generally see that spring wave of something, usually flu, but it's still COVID now. It's the predominant respiratory virus that's circulating. Here's the testing in the county. This is not weighted for sample size, so this is just straight percentage. It's tests, positive tests over negative over total tests. You can see the number of tests that we're doing is relatively flat, but our percent positivity has climbed and is back up near 10% at this point. Again, not weighted for sample size. There's some questions about this in terms of how much we're missing with home testing and folks just not getting tested, but that has climbed in spite of a relatively stable number of tests being done. Testing does remain broadly available through the community, the pharmacies, the Vidant site, the Optum site that is our state vendor site at the mall. So it's relatively easy to get a test at this point in time if you need a test. You've heard a lot about wastewater surveillance. I've mentioned this before, but I've never pulled the graph out and showed you. This is sort of the back end of the curve from January down. And you can see those black crosses are where we were actually undetectable. No COVID in our wastewater in Greenville. And then you can see where that has picked up in line with the cases that are on the epidemic curve. In general, we found the wastewater surveillance to be a good leading indicator in terms of it rises as we're on the rising slope of the wave. It falls as we're going into the falling phase of a wave. So it's definitely on a relatively low trajectory rise right now, in line with that spring wave that we're experiencing. So you'll hear more and more about this, and we think that there's an applicability of this technology to other infections as well going forward.
John, I'm sorry. Could you describe maybe how they do this? Do they just, at the effluent, do they grab a sample and then test it, or how does that work?
They collect from our, the Greenville Sewer Treatment Plant, and that goes to the state lab, and then they count the virus particles in there, the RNA particles in there.
But how do they decide, because there's all kind of dilutions occur in there. How do they decide at what point to collect the sample?
That's a good question, Herb. I don't know the detail of, and thankfully I'm not the guy who has to collect the sample, but it is collected here. The university had done some of this at the actual dorm level, and we were able to identify outbreaks in one of the dorms using wastewater surveillance. So the actual, where do you stick the collection tube and grab that sample? I think it's in the raw sewage. It's in the unprocessed sewage, not in once it's been through the treatment plant.
Yeah.
But
Thanks.
I can ask about that and report back if you're curious.
Not that curious.
Dr. Silvernail, can you give me an idea about what this graph looks like in like the fourth quarter of 2021? And here's my question. So I'm looking at, April and May, the red, and then our yellow right underneath of us. Yeah, sure, it's an uptick, but I wouldn't call it a jump.
No.
Are we expecting a jump to come from this? Because it looks like our most recent data point is maybe lower than the previous.
Yeah, we may be actually just over the hump. My best guess is that the hump for this wave would have been about around the 30th to maybe the first weekend in May. So you're right, that may be down, but if you look at the rest of that, there's some wide variability at times in where these points come up. The overall trend is still rising, with maybe that last data point being down. I'm not confident enough in that one data point to say that we're over the spring wave based on that. And when you look at the the other side of that, I wish they had the whole curve in there, not just from January. You certainly see where the points go up on the December wave, and then for Omicron, we had come back down through the fall after we peaked with Delta around September 11th last fall, and came down and were relatively flat headed into the holidays. We saw some rise after the Thanksgiving timeframe and into early December, but we're relatively flat. And then Omicron appeared. We know our first sample was around December 11th, and Omicron was in there, rapidly displaced Delta, and we hit our January peak, actually about a week sooner than most of us thought. I think our January peak was around the 15th, and most of us thought it would be more like the 20th or 25th. So it went up very quickly and came down very quickly. If you go back and look at that, you can see we're on this, where's my cursor? So here's the fall, the peak of the Delta wave again around September 11th. We fell, we had a little uptick after Thanksgiving, and we were flat until Omicron showed up, and then we just took off and went straight up and then came almost straight down, and then we're down to about nothing, and then picked up again in that spring wave on there. And the wastewater surveillance sort of mimics that when you see the whole curve. And if you're interested, I have those reports and can show you those.
I would be interested in that. Thank
Okay.
you.
Vaccinations in the county, demand remains low for vaccine in the county. We've had over 100,000 folks get at least one dose. That's about 57% of the county. 96,000 change, almost 97,000 complete a primary series. That's 54% of the county, and 45,000, almost 46,000 individuals in the county receive at least one additional dose. So about 25% of the county has had an additional dose, be that for the immunocompromised or a true booster. Talk about the death reporting. I sent some of this out to folks the last week when this came through. That was my Tuesday double HE-double-L day. I was scheduled to be in 4 places at the same time, and one of them was running a little bit early that day, so it kind of made my morning pretty hectic on Tuesday. But we have known that there are deaths that we've identified through surveillance, through contact tracing, through our contact investigations, case investigations. We've known also there are deaths in the vital statistics systems, in death certificates that haven't been added to those. With the go live of NC DAVE, the electronic death and birth reporting system for the state has linked cases in NC DAVE that have a positive test result and COVID mentioned. I'll go through that definition in the data to move those deaths into our public health reporting system and not leave them hanging in vital statistics. So prior to that move, you had to have a positive COVID test, be that a molecular test or an antigen test. You had to die without fully recovering from COVID-19, and we were looking at that point at a 2-week gap between your diagnosis, at least a 2-week gap between your diagnosis and your death. So there needed to be a period of recovery in between in order for it to not be considered a COVID death, and no alternative cause of death identified. And we did actually have an individual with COVID who got shot and died of the gunshot wound and not the COVID here in Pitt County. And that was in the fall of 2020, I guess. The new COVID death criteria require still a positive molecular test or positive antigen test for COVID-19 and a case investigation that determined the COVID-19 was the cause of death or contributed to the death, meaning using the current criteria or the previous criteria, and then a death certificate that indicates COVID-19 is one of the causes of death. There are issues with death certificate data. If you follow public health data, you know that death certificate data is not always the best data to use. It's more subjective on the part of the certifying provider, so providers you don't always have an exact cause of death, and the provider puts their best assessment of that on there, so there is some subjectivity on the part of the certifier in completing a death certificate. In the new definition of COVID death using the NC DAVE data, there is also no time interval specified between positive COVID test and death. So you could have had COVID 6 months ago, and if the certifier says COVID was your cause of death, and you've got a positive test, that's now considered a COVID death. So that's one of a problem with it. And then the case may or may not have been reviewed by public health staff for inclusion in our COVID-19 death count. So in the past, that's been probably the slowest part. It's kind of tedious. We find out that someone died. We think they may have died of COVID. Lee has got to go in and review the medical record and see if they actually died of COVID or died of something else. Was there that period of recovery? So it's a tedious process, and we were sometimes behind in reporting COVID deaths just because they come in and we're limited staff. It's hard to process them. So now cases that have not been reviewed by public health staff, this is an electronic review, are going to be put into those COVID deaths. Bottom line, after this adjustment, looking at the 3 months, and they're not going to do this before the first of the year, so this is only from January through the end of March. We've added 32 additional deaths to our fatality count for the pandemic. This linkage will run on or about the first of every month, and we'll link those potential COVID deaths, or what the state system is calling a COVID death, into our death count. So we will see those numbers run a little bit higher, and it's estimated that may add 20 to 30% to our death total for the pandemic. Questions about that?
I was just going to comment. I mean, I'll never forget reading in an epidemiology text that death is the universal outcome. It's the best outcome that we have. If you start looking at morbidity and other outcomes, they're not nearly as clean. And yet what you've just pointed out is death data is not that clean, because everybody dies from a cardiac arrest.
Mm-hmm.
Everybody dies from a brain death. But what actually were the nuanced things that made the person get sick in the first place, and then what kept them from getting better? And it's almost like the more we know now, the less we know. A gunshot wound to the chest and they're dead in the next moment is real easy. But somebody that's been in the unit for 100 days, it may have started with COVID, but it ended with overwhelming sepsis that was set up, it's just hard.
Yeah, it's one of those things that, we have struggled with, Dr. Garrison. When Lee's looked at some of these cases, we have folks that they may have been in a nursing home and they're sick as heck at baseline. They've got heart failure, they've got chronic renal failure, they're
And this
diabetic.
was a tipping point. It
Yeah.
was right, yeah.
They get COVID, they go to the hospital, they sort of get better from their COVID, go back to the nursing home, so back to their baseline of sick as heck, and then they die. So did they die because they're elderly and have multiple, sort of end-of-life disease states, or did they die because of the COVID? And you could probably show that to 6 different epidemiologists and get 6 different answers,
Yeah. It's almost like infectious disease.
Yeah. Well, at least in infectious disease, though, you can, maybe I can culture it, maybe I can get an antibody or a PCR and prove that infectious agent is there.
No, but
or
I
not.
mean, there's a joke about if you ask 5 infectious disease docs, you get 5 really different answers sometimes.
That is probably true. All right, we did, today we had a visit from North Carolina Department of Health and Human Services at the Health Department. Mark Benton was supposed to be there. Mark did not come. We had the Chief Data Officer for the state was there. Another lady who's over a lot of our women and children's programs was there, and the Chief Equity Officer for the state was there. So we talked for about an hour and a half, covering a rambling conversation that talked about public health data, our services, workforce issues, and health equity. I think it was productive. I think the Chief Data Officer is definitely interested in trying to help health departments modernize our data collection and analysis, and working with the state systems to help facilitate our work. So I think it was a productive time this morning. Want to run through some divisional highlights for you briefly. Administration, as Marcia said, we did submit and present our budget to the commissioners last week. We've been asked to go back and look at some of our position requests and long vacant positions and see if we can merged those two things together. We're still waiting on our final budget. Often after all the departments present to the commissioners, there's a lot of horse trading that goes back and forth between us and the finance office, so we're still sort of in that horse trading state. New office space is almost done in medical records, so we have some new office space that's been created in our medical records area. And I didn't put it in the slide, but we had some folks come through and do cleaning and sealing of our hard tile surfaces this week, and those floors look fantastic after that work was done. Environmental health, Ms. Manning's suggestion, we moved some of our food and lodging staff from office base to field base, and I really think the results speak for themselves. These are the three folks who are on field base now, so they pick up their car and they go to work and basically work from their car and then go home. And you can see that they're all up in the number of inspections that they're doing since that change. These are our food and lodging folks. Here's some of our septic numbers. You can see even though there is a wait time out there, and we're probably 4 to 6 weeks on most of our new septic permit requests, the numbers are relatively comparable from last year to this year. Only down about 3 from March 21 to March of 22. Over the whole quarter, we're down about 22 permits from last year, but we're also at about 50% staffing in that in our on-site wastewater right now. We've been able to fill some of those positions with trainees, but again, the quirks of how the state program works, we often have a trainee in training for several months before we can get them into their CIT course and on to their certification. So working through that, and Angie is on top of that, doing the very best we can with tough situations.
John, that's at third quarter 22. When is your year end for that?
We're July 1st to
Okay.
June
All right, I just wanna
30th.
make
So
sure I was understanding that
yeah,
correctly.
yeah, July 1st to June 30th. So same as the state fiscal year. Health education, annual wellness screenings are underway for Pitt County employees. We've implemented a new wellness software this year that is supposed to make life easier for us as employees to document our screenings and activities and earn our wellness points. Personal health, happy Nurses Day to all my Pitt County Health Department nurses. You guys rock. Our nurses continue to provide COVID vaccine to the community. We are providing our first, second, third, and now fourth doses as allowable under CDC and FDA guidance. WIC sent out a Mother's Day message wishing moms a happy Mother's Day, featuring some of their own family pictures. We are back out in the community. WIC attended the Give Your Community a Boost Health Fair on April 30th. Promotional items such as lanyards, pencils, calendars, a child-focused cookbook, and educational materials were available. Fresh blueberry samples and a blueberry crisp, which I've had some of that before. That blueberry crisp is very good, was offered. And our CVB benefits are increased. Supply chain issues, just a quick update on a couple of these. We have a shortage of certain tuberculosis medicines. Rifampin's in short supply. Rifapentine's also in short supply. Not as bad as rifampin. We have enough to get through folks that we have in treatment now, but we've been asked to monitor that and report that to the state. Iodinated contrast is in short supply, really doesn't affect us directly. We don't order very many studies that require contrast, but the hospital has a plan
It's a
in
big
place.
deal.
Yeah, buku studies done at the hospital for conditions that require iodinated contrast. So that's an issue long-term for the healthcare system. Lab supplies have been kind of hit or miss. When I talked to my lab folks this week, they said they couldn't think of anything that they didn't have, but we've had issues with obtaining the GC medium and other materials for the lab, but this week we didn't have any that we are aware of. That can change fast, though. Workforce, vacancies is noted. We are down 3 from last month, so we're at 28, but that's still, I think, a little over 20% of our workforce is vacant right now. The state did finalize and expand the eligibility for public health nurses, so at least getting folks in the door at the public health nurse 1 level will be easier for us now, so that's good news. As I mentioned, the county manager has asked us to take a look at our long vacant positions for reclassification or abolishment. We'll begin this work next month when I can get my management team back together. In general, I don't see our vacant nursing and environmental health positions as eligible for that process. I think those are positions that we need to fill and not abolish or combine. And that's the end of my remarks for tonight.
John, I would point out that everybody that asks for positions is being asked to look at the long vacant ones. And I would also mention that when there were nowhere near consideration yet of eliminating positions, if and when that does come on the table as a way to get new positions, it's not that those positions would go away forever, but long vacant, and we're talking about year and out positions, would go away. And once that, it could come back and be re-advertised. But that's all is in plan right now, and it's a way to look at the issues of vacancies that have gone on in departments that have large numbers of vacancies continuously all year round. And we've not done a job, we've not in the past identified those positions that are unfilled for really long times. And I don't know the specifics of what y'all have, but I know I've heard some specifics just on those numbers. And it's pretty surprising when you see how long some positions have remained open.
Yeah, we've got a few that are very long-standing open positions, but probably not as bad as some departments are.
I don't think that
And-
what I'm trying to say is that I don't think that's meant to say that that any of those positions are not valued or needed. But if they're not being filled, then the county is going to be reluctant to put the money into that unit. Because right now, every position that's funded is funded for the full year, whether there's anyone in that position or not. So that money goes into the department, and it's a way of looking at how that money is distributed throughout the county and trying to make better use of it as the year goes by.
Yeah, no, I think it's a very reasonable request, and, you know, like I say, my nursing positions are probably not something that we can consider combining or abolishing. My EH positions are not positions that we can combine or abolish, but there's a few straggler positions that we can look at to combine to get those new positions we were asking for, and we hadn't really considered that before.
Well,
so-
nobody had. This is what our county manager, I think, it's new eyes to this job.
I think it's a great suggestion on Janice's part to say, well, you know, before I give you that new position, you've had these two whatever positions open for 5 years. Why don't you combine those and make that position?
And she's also being very careful not to include COVID year data in this, and recognizing that this is an outlier year and that we can't really judge anything on what's gone on here.
Yeah, so, and it's not something that's just being applied to the health department, it's across all departments in the county that request is going out, so. Thank you, Commissioner.
Other questions or comments for Dr. Silvernail? Thank you, Doc.
Thank you, sir.
Any other items of discussion from the board? We'll look for a motion to adjourn.
So move.
Second.
Any opposed? Thank you all, and thank you too.